This is a pelvic CT on a 23-year-old male patient. The patient had pain in the pelvic region as well as lower back pain. This is a sagittal reconstruction of the pelvic CT. As you could tell, this is an advanced musculoskeletal imaging case. Seniors would learn from it, but I think juniors would enjoy it as well. If you're looking for a fracture to explain the pelvic pain, you do have fractures on the right side. Compared to the other side, the right superior pubic ramus is distorted and has cortical disruption. The right inferior pubic ramus is also distorted with a fracture disrupting the cortex. However, the fracture site is associated with some form of L definition and bone formation. And this is what we call early callus formation, which is a sign that the fracture is not acute. It's probably subacute to chronic. Now, proceeding with the case, you'll notice that the symphysis pubis is also distorted. And not only that, there is abnormal widening of the joint here. This tells you that there is resorption at the joint. Leaving that for a second, you notice that the bone texture is totally abnormal. There is diffuse expansion of the bones with lucent areas, which we call lytic areas. Looking more, you'll notice that you have these more discrete, large areas of lytic abnormalities. Such an abnormality is very pronounced in the sacral bone, where you have soft tissue density and expansion. Despite the presence of thinning of the cortex with some areas of cortical disruption, you don't have clear periosteal reaction. And although the density of these focal lytic lesions is that of soft tissue, you don't have a soft tissue component that extends outside. So at least at the sacral region, you don't have an extraosseous soft tissue component. One of the possibilities you might think about when you see such an appearance is that of Paget's disease. Although Paget's disease of the bone could be diffuse, it would be unlikely that every single bone is involved in this fashion. With Paget's disease, you'd have the opposite of what you see here. You'd have increased bone density, bone expansion, and cortical thickening. Notice that you don't have cortical thickening here as well. So what could give you such a diffuse abnormality that leads to lytic and sclerotic involvement as well as bone expansion? You're left with two big categories. This is either a syndrome or a metabolic disorder. You don't have many syndromes that would give you this diffuse kind of involvement, and if that were to be the case, you'd know that from the clinical information. Syndromes that involve fibrous dysplasia might give you something that looks similar. However, this does not explain the whole picture here. Syndromes with multiple enchondromas or enchondromatosis would also not look like this. Fibrous dysplasia and enchondromas deserve a discussion of their own, so we'll leave that for a different clip. Now we're left with the metabolic question. Could this be metabolic? The first hint that we talked about is the resorption at the symphysis pubis. Once you see that, look for resorption at other synovial joints, and the sacroiliac joints are good examples. See here how you have normal cortex, and then you have this area of subchondral resorption on each side of the joint. This is also the case on the other side, on the left side, where you have subchondral resorption. So now, what could give you all these findings in one patient? The most likely explanation here is disease related to chronic renal failure. A combination of renal osteodystrophy and hyperparathyroidism. These two diseases go hand in hand, since the commonest reason to have hyperparathyroidism is secondary to chronic renal failure. Although the patient is young, the hint for chronic renal disease is in front of you when you see calcifications of even the smaller vessels. So severe atherosclerotic changes of all of the large and small vessels, that's a good hint to long-standing renal failure. This is even more the case when this is seen in a young patient where atherosclerosis would be unexpected. With hyperparathyroidism, there is bone resorption since the body is trying to mobilize calcium from the bone into the blood, and that results in classic locations of subchondral resorption, such as the symphysis pubis and the bilateral sacroiliac joints. When resorption is so rapid, hemorrhage may occur inside of the bone. As the bone tries to repair itself in the hemorrhagic area, you'd have granulation tissue and fibrosis. This may lead to a focal soft tissue lytic area known as brown tumor. So now you understand that what looks like a tumor is not actually a tumor. It's not even a neoplasm, it's just a reparative process secondary to resorption and bleeding. You now understand why these tumors may have soft tissue components, cystic appearance, or even hemorrhagic components. Knowing that the bone is totally abnormal, this explains why the patient has fractures at multiple locations. These are all pathologic fractures, fractures of abnormal bone. Now, what explains this area of increased bone density or sclerosis? Since this is the opposite of what you expect with what we just described with hyperparathyroidism and bone mobilization. Don't be surprised to see that, since this is the manifestation of renal osteodystrophy. In fact, one of the major possibilities for increased bone density diffusely is that of renal osteodystrophy. Now to something more interesting for the senior audience. I showed you the sagittal reconstruction of the pelvis. You also see how the brown tumor at the sacral region extends into the spinal canal. There is a diffuse involvement of this fifth lumbar vertebral body with subsequent pathologic collapse. However, have you noticed the appearance of the vertebral body above? There is subchondral sclerosis of the superior and inferior end plates, sparing the mid portion. This is such a classic appearance of the spine with chronic renal disease known as rugger jersey spine. For those who don't know, rugger is another word for rugby, and this was called like that because this simulates the jersey of a rugby player. And here's the classic appearance that most of you are used to on a lateral lumbar spine x-ray. So let's summarize what we talked about today. When you have expansile lytic lesions of the bone, there are a few possibilities. The classic three signs of Paget's would be bone expansion, coarse trabeculation, and cortical thickening, which we don't see here. Fracture with the abnormal underlying bone is called pathologic, and if you see callus formation, it's not acute. The classic signs that you would see with the hyperparathyroidism would be subchondral resorption in joints such as the sacroiliac joint and symphysis pubis. You may have focal lytic lesions with hyperparathyroidism known as brown tumors, which are not tumors, they're hemorrhagic reparative processes. Look for other hints for renal disease such as severe atherosclerosis even in small vessels. especially in a young patient. Renal osteodystrophy would give you areas of sclerosis. And remember the rugged jersey spine as a classic sign for renal osteodystrophy. With that, I thank you for watching and see you with more cases later. This is a chest x-ray on a 49-year-old female patient who presented with coughing episodes. And here's the lateral chest radiograph on the same patient. The abnormality is this well-defined homogeneous opacity that projects over this region. For a better descriptive term of this area, this is called the right cardiophrenic angle compared to the left cardiophrenic angle. So you have the homogeneous well-defined opacity that projects over the right cardiophrenic angle. This is a relatively common finding in chest imaging, and the differential diagnosis for such a finding is very classic. The differential diagnosis for a right cardiophrenic angle lesion includes a pericardial fat pad, which could have various densities on a chest radiograph depending on many patient or chest X-ray technical factors. One classic descriptor of fat pads is the relative well-defined appearance with a homogeneous lower density than expected, meaning that the opacity does not obscure the underlying lung markings, such as these vessels here, and do not create a silhouette sign with the diaphragm or the heart. So there is no obscuration of the hemidiaphragm or the adjacent cardiac border. Although we're favoring a fat pad here, other differential possibilities would include a pericardial cyst or a hernia through the diaphragm. Such hernia in this location is called a Morgagni's hernia. This is also a possible location for lymphadenopathy from infections, neoplasms, or other conditions. And less commonly, you might have a thymic lesion that resides in this location. To complete your approach, make sure that this is not arising from the pleura. If that's the case, this might be a fibrous tumor of the pleura. Also make sure that this is not a lung parenchymal abnormality, such as pneumonia or right middle lobe collapse. However, with lung parenchymal abnormalities, the findings wouldn't be this well defined. They'd typically be more dense and more heterogeneous. If you go to the lateral radiograph, the opacity is not as easily appreciated since it projects over the cardiac shadow. Just as a bonus kind of thing, have you noticed this? Yes, this is a coronary arterial stent that we showed in a previous case. This is a CT correlation on the same patient. As you see, you have this abundance of fat in the anterior mediastinum, which continues with this excess right cardiophrenic angle pericardial fat. So this is a large pericardial fat pad. Note how the density is similar to that of subcutaneous fat. So to summarize, let's remember the differential diagnosis of a right cardiophrenic angle lesion. As long as you're sure this is not arising from the pleura or lung parenchyma, the major consideration would be that of a pericardial fat pad. This is followed by a pericardial cyst or a Morgagni's hernia. Also make sure this is not lymphadenopathy from any reason or rarely a thymic lesion. And that's it for today's case. Thanks for watching. Send your comments as usual and see you with more cases later.